Sorry.
Okay, we'll see you, Tom.
Still? How's it going? Yeah, yeah, I drove up
Can you guys hear without the microphone?
Yeah.
We need the microphone. Here's the difference. Better? Microphone, yes. Microphone, yes. So we have limited numbers.
So, as Debbie said, we will have a limited number of mics today. We'll be sharing mics at the table. So, we definitely would like, if you all can't hear, raise your hand and say, can't hear. So it'll be a reminder for folks on the task force to use the microphones. So my name is Blake Marsh. I'm one of the executive directors at the Department of Health and the Office of Health System Quality Assurance, Division of Health System Quality Assurance. And I'm co-leading with Chris Baumgartner on this project. We always like to do, as we're getting ready to get rolling in the morning, a quick update and recap for people, because we realize that as we're doing these meetings, we're moving around the state, and that not everybody has the opportunity to participate in all the meetings. And so just to recap what it is that we are doing in this project and so far. So the bill that passed in the last legislative session that is driving all of this work, House Bill 1427, it has a number of different moving parts to it, but its goal is to help to curb excessive prescribing that is leading to some of the opioid addiction problems and overdoses that we're seeing in the state, while balancing off ensuring that people who need pain management in various stages of care are getting appropriate and safe care. The bill has a number of different parts to it. It authorizes health officer and other government access to prescription monitoring program data. It authorizes healthcare facility and group access to prescription monitoring plan data. It also authorizes hospital CQIPs, which are quality improvement programs, to use the PMP data. And it authorizes prescriber feedback reports based on the data that comes out of the prescription monitoring program. The big part of why you see these people up here at the table in front that is in House Bill 1427 is it also authorizes 5 boards and commissions to write opioid prescribing rules. And you may know that in 2010 and 2011, these same 5 boards and commissions worked on writing chronic non-cancer pain rules. This is an expansion on that effort. It does allow the boards and commissions to revise their existing chronic non-cancer pain rules, but it also will offer them an opportunity to write rules for acute care, subacute care, perioperative care, as well as other topics like tapering, co-prescribing, whether or not there are special populations that need special consideration, alternatives to opioids for pain, and the use of PMP data. So the November 15th meeting that we had in Yakima was a very full meeting. What we did was, it was the first opportunity we had to actually look at some draft or discussion language, rule language, particularly in the areas of acute pain, prescribing, and revisions to our chronic non-cancer pain rules. In addition, we had the introduction of 2 new topics. We had guest experts here to help the task force talk through what are the relevant issues in perioperative prescribing. Dr. Greg Turner from the UW was our guest expert for that. And then we also discussed special populations. And we had Dr. Gary Walker, who's here today, along with Dr. Mark Code, from the Yakima Valley Farmworks Clinic, who's the Chief Dental Officer over there, to talk about the special populations. As I talked about in the last meeting, and I want to stress here as well, for those of you who aren't necessarily familiar with our process, the task force today is not charged with actually making the rules. They are representatives of the 5 boards and commissions. And what their role is to help develop a conceptual draft or some boilerplate language that will then be used by the 5 boards and commissions to actually promulgate rules. And that boilerplate will go back to each of the 5 boards and commissions for further deliberation, and then they will take on the formal rulemaking process that we hope will conclude by the end of 2019, or 2018, excuse me. The rules are supposed to be adopted by January 2019. The next steps, today's the 4th of our 7 meetings, and our hope is to do a complete run-through of the rules. We're going to do a more thorough review, a more in-depth review of the language. We also hope to get direction from the task force for beginning to work on co-prescribing rules. And we'll have a couple of experts come and talk with the task force this afternoon about that topic. As we've done in the past meetings, we'll continue to have opportunities for input from technical experts, from our associations, and from the public. And we do that at all of our meetings. And there will be times during the day when we just are having task force discussion, and we have the technical experts available if they have questions. But we, like I said, we do value the customer feedback and stakeholder feedback and the public feedback in this process. And there are a number of ways that you can contribute to this process. You can certainly provide testimony at the meeting if you'd like, but we also have a separate website, which is www.uh.law.gov/opioid prescribing, all one word. And we put basically everything that we can related to this project on the website. So if there's something here, a presentation you see, or a draft that you see that you'd like more information about, or if you hear a reference to a report, you can go there, and we try to put everything up so it's very transparent. We also have a survey function on the website, so that if you want to provide feedback, you can provide feedback in a way that's very similar to how the task force is dealing with their new issues. So each issue that they talk about, they're using a facilitated model for discussion, and the survey models that. So it's a really good way to tailor your comments to something that will be useful and easily accessible to the task force. And just a final reminder that, as I said before, the 5 boards and commissions will individually make rules based on the work of this task force. So each of the 5 boards and commissions will be providing opportunities for comment as well on the rules that they need along the process. So, with that, I'm going to turn this over to Debbie now. That's a brief recap on where we're at, and I'm going to ask her to kind of lead us into the
All right, let's see how I do with this microphone and my handouts as well. My name is Debbie Ruffback. Welcome, everyone. I have been hired by the Department of Health to facilitate conversation about among the opioid task force members to hopefully gain consensus about opioid prescribing, as you heard about. I hope that each of you who are here have picked up the handouts that are at the back table. We're going to go over a couple of those. You will have an agenda today, which is reflective of what's on the wall over there. That helps me that it's on the wall. There is a document that looks like this, and that is a kind of a table of contents envisioned about the types of, or the number of rules that we'll be looking at. The dots there, the colors, represent a prioritization that the task force members undertook when they very first met. The order in which, or the priority order in which they wanted to talk about these conversations or talk about these topics. Red represents the thing that they had the most passion about. Blue represented the second most, and the others were important, but if we had to focus on some, that's what we wanted to focus on. There's another document that looks like this. It talks about the opioid prescribing and monitoring project roles. So I just want to review that for you. Some time to figure this out, there's an agreement around it. You'll see that the members around the table, the opioid prescribing task force, represent, there are 2 members from each of the boards and commissions. The members that have a vote in this process have a white name tent. We also have been tasked by the bill to include the Pharmacy Commission, members of the Pharmacy Commission, as well as our 2 project sponsors, Blake and Chris Met. We have also engaged the help of some technical experts. If you are a technical expert, you may be sitting in that front row, and we may take comments from you during the presentation. If you are not in that considered a technical expert, we will not be taking your comments during the meeting except for designated time. So I want to just point out, Blake mentioned this already, but for the members of the public, if you would like to make a comment, we encourage you to sign up. There's a sign-up sheet outside the door. And our public comment period today is at 11 o'clock. We ask you to focus your comments on the draft rules that we'll be discussing. If you have additional comments that you'd like to offer beyond that 11 o'clock time slot, we encourage you again to send in your notes via the DOA website. Okay, I also want to remind you that this is considered a public meeting, so any comments that you say here may be considered part of the public record, as well as people may be using their phone to stream or record. So just keep that in mind. Okay, you'll see that on the agenda that you have, at the, I think it's 9:30 time slot, there's a break. Just a brief little, there's a black line in the agenda, and that's because there's a separation of the 2 projects. People who are interested in the prescribing, monitoring, and public input part will be going over to a different room, and the members of the opioid prescribing task force will be staying in this room to review the draft rules. What else we got here? There will be a lunch that is a working lunch, and lunch will be provided for the task force members. We unfortunately are not able to provide lunch for members of our audience, but there is a cafe and some resources out in and around the area for you. The lunch may be a working lunch because we've got a lot to do today. Full agenda. Again, we're pleased to have some subject matter experts joining us today, that'll be this afternoon, on the topic of co-prescribing. Okay. So, what I'd like to do now is ask for introductions. We'll find out who's here. And we're going to start with members of the audience, and then we're going to end with our members of the task force. We'll give you guys an opportunity to offer a little bit of additional information, okay? So if you don't mind, I'd like you to say your name, and if you're representing somebody or some group, please say that as well. You're interested in being here today. Yes, and because we have limited use of microphones, we might have Chris play the role of somebody passing things around.
Good morning. I'm Gary Walko, a professor of anesthesia at University of Washington and director of pain medicine at Seattle Children's Hospital.
Is that on? Say it again, please.
Instant replay. I'm Gary Walko, professor of anesthesia at University of Washington and director of pain medicine at Seattle Children's Hospital.
I'm Ichua, I'm a pediatric emergency fellow at Seattle Children's.
Hi, I'm Bob Small. I'm a psychiatrist, commissioner on the Medical Commission, and a member of the Committee of the Medical Commission for Foundation of the
Micah Matthews, Deputy Executive and Legislative Director of the Medical Commission.
Hi, my name is Cindy Hohenhaus. I am a chronic pain patient. I belong to the Alliance for Treatment of Intractable Pain, and we're here to make sure that we'll still be able to get our medications when the process is done.
Charles Hohenhaus, caretaker.
Rose Pigham, also a chronic pain patient and one of the directors of the Alliance of Treatment of Intractable Pain. And as Cindy said, we're here to ensure that the 600,000 disabled chronic pain patients also retain access to safe, effective medication.
Good morning, Brett Kane, Department of Health staff. I work with the osteopathic board.
Heather Carter, I'm Attorney General and I'm in the board.
Jennifer Santiago, I'm Program Manager for the Dental Commission. Trina Crawford, Executive Director for the Dental Commission.
My name is Joanne, I'm a nurse practitioner. I've been caring for folks with chronic pain for over 8 years.
John Wilson, pain management specialist. Howard Quick, also pain management specialist. I used to be a surgeon. I worked in psychiatry, addiction, disability, and research.
Don Joff, I'm the president-elect of the Washington Medical Association. I'm a family physician from Spokane, and I have clinical experience in hospice as well as secretary.
Jeff Shepard, staff of the Washington State Medical Association.
Jessica Pearson, representing the Washington region of Kaiser Permanente.
Morning, Maggie McDaniel, I'm a clinical quality assurance specialist for Virginia Mason Medicine.
Amanda Locke, I'm an ambulatory pharmacy manager at Virginia Mason Medical Center and also the pharmacist provider in physical medicine and research at the
Dan Warren, pain specialist and anesthesiologist from Virginia Mason and part of our teaching on opioids and schools.
Rolf Christensen, dentist, University of Washington, full-time faculty, also director of dental urgent care up there.
Lori Grassi, Executive Director, Washington State Chiropractic Association.
Brad Fine, the King County Department of Community and Human Services.
Angelica Foley, pharmacist consultant for the Pharmacy Quality Assurance Division.
Amanda Avalos, Washington State Healthcare Authority.
My name is Sylvia May. I'm a Doctor of Nursing practice student at Pacific Lutheran University.
Carl Owen, Legal Manager, Nursing Commission.
Good morning, Paula Meyer, and I'm the Executive Director for the Nursing Commission.
Chelsea Marco, I'm a clinical pharmacist at Harborview, working with psychiatry and addiction.
Christina Bachman, I'm a pharmacist at Harborview, working in pain management, and I also am a person who is on
Good morning, I'm Jody Perlmutter, I'm the Executive Director of the Washington Osteopathic Medical Association.
Stephen Stanis, I'm Medical Director of Swedish Pain Services and President of the American Academy of Pain Medicine.
Rick Sherman, anesthesiologist, pain management specialist at the University of Washington.
I'm Daryl Owens. I'm serving as a technical advisor in the Nursing Commission. I'm currently the Section Chief of Supportive and Palliative Care for Good Medicine at Northwest Hospital and the Founding Director of the Palliative Care Department.
My name is Gail Yu, Assistant Attorney General. I represent two of the boards here today, the Nursing Commission and the Podiatric Medical Board. Here I understand there's a petitioner here for the Nursing Commission for 10 and clinical practice for also working currently in pain management and in healthcare compliance management.
Ryan Distressy, Assistant Chief Pharmacy Officer with the Washington State Healthcare Authority.
Jamie Mai, Labor and Industries, and part of the agency medical director group.
Michael Rakawa, Physician Assistant, representing Washington Academy Physician Assistant.
We move it to your camera.
Josh Morgan with the Como News Channel 4.
Do you mind bringing that here too?
This is the Nursing Commission. Good morning, I'm Melanie De Leon. I'm the Executive Director for the Medical Commission. Adria Underwood, Program Manager, Medical Commission.
Martin Biccioni, I'm the Director for the Office of Health Professions at the Department of Health.
Good morning, I'm Lily Lopez, Assistant Attorney General. I'm serving as General Advisor for the task force and the department.
Hi, I'm Kathy Hoffman, Policy Analyst, Department of Health, Office of the Assistant Secretary.
Good morning, Gary Garrity. I'm the Operations Manager for the Prescription Monitoring Program at the Washington State Department of Health.
Thank you. Okay, now we're getting to the members of our task force. So let's see first.
Susan Bragg, Health Staff for the Podiatric Medical Board.
All right, now we're at the members of our opioid prescribing task force, and I would like for you to say your name, your association, and why it was important to you to be part of this process. And Blake is a sponsor, so we know why that's important.
I know what to do it again.
Yeah.
Hi, Kat Kachatorian. I'm a pharmacist, member of the Pharmacy Quality Assurance Commission. I spent 10 years in community pharmacy practice and the past 8 years in managed care. It's important for me to be a member of the task force because I want to ensure safe and effective use of medications, as well as operational efficiency of the process as it's implemented to ensure patients have access to appropriate care.
Good morning, Jerry Allen. I'm also a member of the Pharmacy Quality Assurance Commission. I'm a public member. I'm not a pharmacist. And my interest today is to look at how we can better reduce the tide of the opioid epidemic while at the same time ensuring patients have access to the medications they need.
DJ Wardle, the dietary board, still trying to get off of I-5. Anyway, I'm here to help lend a hand in trying to come up with a plan to solve this problem with the opioids, not only for us on the acute side, but the chronic side as well.
Alden Roberts, I'm from the Medical Commission.
Could you speak up, please?
Yeah, I'm Alden Roberts. I'm from the Medical Commission. My background is in general surgery. My interest is in optimizing patient care and patient safety.
Chris Baumgartner, I'm the Drug Systems Director at the Department of Health, so prescription monitoring is in my section, and I have the legal book.
John Carberry. John Carberry, Yakima, Washington, representing the dental commission. Went through college pharmacy from dental school, very much concerned with the misuse and abuse of medications, and look forward to lending a hand.
Good morning. I'm Helen Myrick, and I'm a public member of the Nursing Care Quality Assurance Commission. And I'm here to tackle this crisis in our community, similar to what I did in the early 2000s with the meth epidemic that we faced, and particularly concerned about the impact that it has on children and families. And so just hope to make a contribution. Thank you.
I'm Claire Trescott. I'm a family physician and a member of the Medical Quality Assurance Commission. I'm here because some of it is my past background. I'm a past president of the Washington Society of Addiction Medicine and have worked with patients with chronic pain and addiction. And I also was the medical director of primary care for health for 10 years. And during that time, we set up standard approaches to managing patients with chronic pain. And it matters to me that we are focused on really high quality, respectful care for all patients. And also that we have the voice and frontline position on this board. I'm currently practicing in emergency care for Kaiser's, so I see emergencies clinical practice. And it matters to me that we keep all of this work respectful and high clinical quality.
Hi, I'm Shannon Betts. I'm a family practice as well. I'm on the board of osteopathic medicine. And as for why I'm here, that's always a really thought-provoking question. And what I realized is I'm here because, much like Dr. Trescott, I'm a strong patient advocate. And while not every patient is a provider, we all need to keep in mind that every provider can be a patient too. So I think that it's a very complex issue and a very complex situation, but we all want the best for every single patient, and we all want to maintain a high standard of clinical quality as well as access to the community.
Hello, my name is Ron Marsh. I represent the Dental Quality Assurance Commission. I'm a board certified oral and national facial surgeon. I'm also a board certified dental anesthesiologist. I've been in practice in Washington State in 2018 for 30 years. I have a personal interest in having opioids prescribed safely and effectively, very, very quickly.
Thank you. All right, welcome everyone. Thank you all for being here. We are have really a very full agenda. We're going to be getting to draft rules soon, but before that, we're going to hear from Chris Baumgartner, and he's going to talk about the prescribing data. It's going to entertain us all day long. Prescribing data for Washington State, and I'll let him say a little bit more about that, Chris.
Thank you. So at the task force meeting in Yakima, the group had asked for what is the prescription monitoring program data telling us about prescribing practices in our state? And thankfully, that's something we have been working on. And so I'm going to talk a little bit today about some aggregate data we have on prescribing practices in Washington State and show you where you can access that in case you're interested in looking into it further. So today I'm going to talk a little bit about a data background, an introduction, and a little bit of some of our metrics that we have available. We've developed six metrics for this. And at this time, I'd like to introduce Mariana Rosenthal. She can just wave her hand briefly, but she's our supervising FE for prescription monitoring program. And so her and her team are really tackling this work, so I have to give them credit for this. A little bit of data background on the prescription monitoring program. In case you're unfamiliar with it, we collect all Schedule 2 through 5 controlled substances in Washington State. So any licensed pharmacy that dispenses in or into our state, as well as practitioners who dispense out of their office, have to provide that data to us. We require daily reporting, and we collect about 12 million records a year, so that's a lot of information. Some of the information you will not find in the prescription monitoring program. Again, if the prescription was dispensed in another state, not into our state, you won't see that. If it was prescribed for less than or equal to 24 hours, it's exempt. Inpatient care is generally exempt as well, and we don't get information from opioid treatment programs who are covered by federal laws that protect treatment confidentiality. But we do have some reporting coming in voluntarily from the Veterans Administration, Indian Health Services, tribal-run pharmacies, but not from the Department of Defense. So that is one other area where if you have a patient who's receiving prescriptions at Madigan, for example, we won't see that in the data. A couple of things to make note of as well that changed some of the way our data looks along the way was two products that got rescheduled by the Drug Enforcement Administration. Tramadol was previously not scheduled until, I believe it was August of 2014, and so that came into the picture, and then all hydrocodone products were also rescheduled later that year, all to a class 2. So what are the BREE metrics? For those of you who might not be familiar with the BREE, it is legislatively established, and it's kind of a public and private insurer partnership that looks at tackling broad healthcare issues that impact the whole state. And so the BREE collaborative met and created a new project around opioids and wanted to really develop a series of metrics that could be used by both the state as well as private insurers to really measure what does prescribing practices look like in our state, and are we improving? Are we making proper moves towards best practice when it comes to opioid prescribing? So that's really what I'm going to focus on today, and I'll even try to give you a brief demonstration live of what that looks like, but if you go up to the Washington Tracking Network, there's a new section there that provides this data that you can look at yourself. So our first measure that I wanted to share with you and show is basically just generally looking at the total number of patients per population that received an opioid prescription during the calendar year quarter. So all these metrics are tracked quarterly, and we're looking at this one just simply in Washington State, how many people each quarter are receiving at least one opioid prescription. We have some breakout by age classifications for that. And so this is kind of what you'll see on the website and what it'll look like if you do the age comparison ones. You can see for different age group categories how many people within that age group have been receiving opioids. We also have some data we're hoping to make available later at both the accountable community of health level as well as the county level to help out with a little bit more regional approach to looking at this problem. So that isn't live yet on our website, but if you email us, we can certainly make it available to you in a PDF, and we'd be happy to do that. Patients with chronic opioid prescriptions is the second measure. So here we're trying to track trends in people who are chronically taking prescription opioids. So we're looking at people who have 60 or more days supply of opioids during the calendar year quarter. That's kind of our definition. And again, it's a population-based rate. So we're looking at how many per thousand residents are chronically taking opioids based on that definition. And so you can see there that looks like we're at about 20 out of 1,000 patients per quarter typically are chronically taking opioids from the data we have available. Again, we have some data available at the ACH and county level. The third one is patients with high-dose chronic opioid prescriptions. So these are folks who are taking more than 50, more than 90, or more than 120 morphine equivalents a day. So these are also people who are already chronically using opioids. So they not only have 60 days or more supply during the calendar year quarter, but they also are hitting one of those morphine equivalent thresholds. We know that the CDC has 50 and 90 in their guideline, and then of course in our current chronic non-cancer pain rules that are looking at being amended at 120. That's why we picked those cut points. We didn't randomly choose them. So this is kind of what that looks like for those three marks across the state. As you can see, the majority of our chronic opioid patients are on 50 morphine milligram equivalents a day, not 90 or 120. Although those rates are staying fairly steady. The next one is patients with concurrent opioid and sedative prescriptions. There's been a lot of look at best practice around the risk associated with overdose when you combine sedatives and opioids. So we're looking here at the number of folks each calendar year quarter who've received both an opioid and a sedative. And those are the sedatives we have listed in case someone wanted to know specifically which medications we included. And when you look at that, there's a little bit of a downward trend, but again, we're hovering right between, looks like 15 and 20 per 1,000, that are having that situation each calendar year quarter. We also looked at patients with new opioid prescriptions by day supply. That's also been a lot of focus is, how many initial day supply are you giving someone for an acute injury? And so we have a couple of, again, cut points there where we're looking at a couple different situations where it's like less than 3 days supply, 4 to 7 8 to 13 or greater than or equal to 14 days supply for that initial opioid prescription for an acute setting. And again, this is someone who is not chronically using opioids, so we excluded anyone who's chronically using opioids. So you can see some variation there as well between those different day supply ranges. Finally, our patients with new chronic opioid prescriptions is the last measure, and the concept here is we look at the previous calendar year quarter and make sure they're not already chronically taking opioid but had an acute opioid. And then in the next quarter, we're seeing, did they transition to having 60 days or more supply of opioids? Trying to really get a gauge for how many people are transitioning from acute to chronic, because obviously that's something we're hoping to minimize as well. And again, it's per thousand population. Again, to note here, we may have some interesting wrinkles with the fact that tramadol got rescheduled that year. That may impact some of the data because we didn't have any tramadol prescriptions before August 2014, and then suddenly it's scheduled and we start collecting it. And it's actually one of the top, I believe, 5 controlled substances now that we look at as far as total number dispensed. With that, I'm going to pause and see if there's questions, and then I was going to actually give you a little demo on the live website itself. I wanted to move through those fairly quickly because I wanted to make sure we had time for a discussion. But feel free to contact my staff again if you'd like to see that data at the county or ACH level as well. We're hoping to make that publicly available on the website soon. But currently what we have available online is just the statewide level data. It's on your sheets right there. Any questions I can take from the task force at this point before we do a little bit of a demonstration? I know this was something with task force. Absolutely.
When you say 3 days supply, is that a maximum dose?
So we take days supply based on how the pharmacist entered it into the prescription monitoring program. And I think our pharmacy experts here can correct me if I'm wrong, but my understanding is when a pharmacist gets a prescription, typically day supply is looked at for how, based on PRN, how quickly will this prescription run out, and they maximize that. So if you said, 1 to 2 tabs every 4 to 6 hours, they're going to assume 2 tabs every 4 hours, and that's the day supply that's put in. Correct. And so we take day supply based on how it's inputted from the pharmacy system. But to be clear, yeah, if you give someone a PRN with a range, we're going to see the day supply and this person using this max capacity around the clock.
That's a place where a lot of docs are going to have to start being very careful because in a lot of the automated systems, they'll see a field for days that defaults.
Right.
30. If you leave that default at 30, guess what? You just hold how long does that prescription have to last rather than 3 days. You just hold the system at 30.
Right. That's a very good point. A lot of them have a default already preset for you.
Right. You have to change it if you're specifically going to.
Right. And I know some health systems have been considering actually changing that default within their electronic health record system or e-prescribing system. Are there other questions I can help address on the tracking network data points? Well, let me give you a little demo real quick, and then we can see if there's any additional questions. But I hope this was helpful in helping you see and be able to track these trends. And a lot of these, as you can see, impact the work you're doing as you look at, say, supply considerations, as you look at sedative and opioid prescribing concurrently. But if you come to the Washington Tracking Network website, there's a new section for prescription and drug overdoses. So you can also look at overdose data if you want to. But right here, you would select your measure, and we're going to look at patients with prescriptions. Again, you could look at drug overdoses if you wanted to. And then all the measures I talked about are listed right here. So we could look at, what would people like to look at? What one interests you?
Hi, Valerie.
Anybody? Do I have one? We'll go ahead and go with patients with high-dose chronic opioid prescriptions compared across the different types of MED thresholds. That's what started. Again, further geographies will hopefully be available soon. Right now, it's just the state level. But if you want, you can see the different notes there. And when you submit it, you're able then to go ahead and look at the actual graph. Once we do have it available at the ACH and county level, there should be maps available as well. But you'll notice when you get in here, there's notes so you can understand how the measure was created and any caveats with our data. You can look at the actual table of data and download it if you'd like to work with it. There's an export button, and then again, you can actually look at the chart. So across the top here, you can see that for 50 morphine milligram equivalents per day, we're right around that 7 to 8 per thousand rate of people typically who are on chronic opioid therapy, 60 days or more in the quarter, and at least on 50 MME. For 90, we're at right around 4, although that is trending down. Looks like in the last quarter we were down to 3.
Chris, that's per thousand what?
Per thousand residents statewide. And again, when you look at county or ACH, that'll be based on the population of those counties or ACHs. So you'll be able to actually look at your region and your county and determine if your rate is different than the state. And then again, for those who are on 120 MME or more, we're right at, looks like we're tailing it down to just about 2 per thousand in each calendar year quarter by the end of 2016. So that's one example. Are there other measures that people would like to look at briefly? Yes, please. Absolutely. So again, if we come back here and pick a different measure, we can go down to patients with new chronic opioid prescriptions, because that's the transition. Zoom it back. Look at our trend line. And again, we have a bit of a funny bump in 2015. We're trying to figure out if there was some data discrepancies there. But basically, at the end of 2016, we're down to really only 1 per thousand. So there has been a bit of a tailing off here, but it's overall stayed fairly consistent. Again, there may be a data anomaly here we need to work out in 2015 with the pharmacy change. Yes?
Jobs for the patient that processed and very careful patient for billing in March and April for process Q1. Was that reflected there too as the patient was then?
Yeah, this looks at the previous calendar year quarter and makes sure they weren't already on chronic opioid therapy in the previous quarter, and now they are in the current quarter. So it does look to account for that in the way it calculates the rate. Are there other questions or any of the other metrics that people would like to see?
Do you have the one on the days?
Yes. That would work. So patients with new opioid prescriptions by day supply. So this is 0 to 3 days. Let me find the compare. So here's all of them. So again, these are patients who received an acute prescription during the quarter, so they're not chronically using opioids. And you can see that on the 0 to 3 day supply, we're at about kind of paying between 40 and 50 persons per thousand. And then when you get down to 4 to 7 day supply, there's about 34, looks like on average, although it's trending a bit up here towards the end, more to almost 40. And we're looking at around 11, looks like on average they're getting between an 8 to 13 day supply. And then when you jump down to greater than 14, but again less than 60 because we don't want to count chronic users, by our definition we're right around 7.5 by the end of 2016.
Based off the graph.
No, I think that's correct. I think that's pretty safe to say from this chart. Everything's pretty flat from Q1 to 2012 through Q4 2016. Absolutely. So if we jump back here, we can jump actually back up to drug overdose fatal. And Dr. Trescott, would you like to look at all drugs combined or just opioids, just prescription opioids? How would you like it broken out? Just all opioid fatal overdoses? What's the you want opioid? Yeah. This is all opioid fatal overdoses. So here you, sorry. Yeah, it's not switching from measure focus, so I just wanted to try to get okay, so there we go, switch, sorry, let me switch to opioid. this is the trend line for all opioid, prescription and illicit combined. And we're at about 10 per 100,000 right now. And that's been pretty flat. It's when you look at the breakout by different types of opioids that it gets a little different. So yeah, here's any drug overdose at the top, so that would include meth, cocaine, any type of drug overdose. The light blue is all opioid overdoses. The red is prescription opioid overdoses. You can see we have had a good downward trend there. The green is heroin, and that's why the overall opioid deaths aren't really down, because the heroin has gone up. And then again, we have what we would call synthetic opioids at the bottom. That's where we're trying to track illicit fentanyl. We haven't seen a lot of it in our state yet, but we're trying to keep a careful eye on it, because in some states, especially back east, that has really become a huge problem. So we should have 2016 in here hopefully soon. I don't think that's been, probably not been put in for the overdoses yet. I don't think there were any large changes in 2016. Yes?
So were there any changes in required reporting for housing deaths or during this time?
Not that I'm aware of. I mean, we're always trying to communicate and work better with the medical examiners and coroners, but I don't think there's anything in particular that our FEs are finding that they think would account for the, based on just, more scrupulous reporting or more attention to detail there.
Is it possible to turn non-fatal to fatal?
We don't have non-fatal in here yet, but that is another thing we're hoping to add. And we're hoping to actually come up with basically an opioid dashboard where, yeah, you can look at hospitalization, non-fatal overdose, fatal overdose, and prescription metrics. That's our goal. It's hopefully in Q1 of next year we'll have that developed and pushed out and available. But I did want to share with you what we have to date, because I know that was something the task force has to look at. And hopefully this helps you as you're reviewing some of the decision-making around prescribing. Yes, Dr. Yeah.
Is there I see you reported on an increase in heroin overdoses?
Yes.
But you have illicit fentanyl, so I imagine 15, 16.
Yeah, that's right here, this bottom line, the synthetic. We haven't seen a huge amount yet, but again, we're keeping a very careful eye on it because we know it's becoming a big problem in other states. It is. Our state tox lab is getting a lot better at it, though. Correct. 2016 should be up very soon. Our FEs, it's a little more challenging than getting the PMP data up because you're working with 39 different medical examiners and coroners across the state. So, but they do plan to get that up pretty shortly.
Is this the data that's fed into the CDC for its national measures?
That's my understanding. Maybe Mariana can, yes, we'll take it in. Yes, absolutely. Yes.
Is there any intent to track also
We have had several requests to try to track units of naloxone. I think that's the kind of yin and yang of making it so publicly available, as there's no great way to track it. Because so many different people can possess it and distribute it now. It's given out through syringe exchanges, through pharmacies, through standing orders by health directors, and so it's good that it's widely available, but it's very hard to track because of that.
Is there any idea what you had in 2006
On the prescription side? Yeah, I mean, I think, and Jamie can chime in here too, but I think a lot of the work our agency medical directors group did with their initial opioid prescribing guideline, that was coming out in this time period. The PMP came up then in 2011, and we had other, it's really a combination of efforts, but back in 2006-07, the biggest thing I can think of that happened was the medical directors group came out with their first dosing guideline. Oh, sure, from 2000 to 2006. I mean, the original rise in prescription drug overdoses, I think, is largely tracked to a number of factors. One, pain being recognized as the fifth vital sign and bringing a lot more attention to it. I think there was obviously a lot of marketing of opioid medications by the pharmaceutical companies, and a lot of unfortunate misinformation out there about the potential risk for addiction and overdose that was reported to providers. And they felt, very comfortable and confident prescribing these medications fairly liberally. Jamie, correct me if I'm wrong, but I think that's basically our consensus at the state agencies.
Yeah, the trend pretty much tracks utilization of prescription drugs.
Yeah. one graph the CDC loves to show that we don't have here, but it shows deaths and sales of pharmaceutical opioids, and they follow each other like exactly right up the chart. I do want to be mindful of time. I think we probably need to close out, but feel free to contact me and my team if you have other questions around these. Hopefully it was helpful. Yes, one more.
Can I ask you about, is there any inclusion of medical examiners to report opioid deaths? Is there any way to facilitate that reporting? Like we facilitate some ordering, like in the public health department, report to.
Yeah.
Is there any requirement for medical examiners?
My understanding is our vital statistics unit does work directly with them, and that is required to report to them. It's just the challenge of, the tox screening has to be done, and their final analysis has to be done, and closing out about, there's on the prescription or opioid side, there's at least 700 deaths roughly a year, so getting all those closed out and in just takes some time, but it is required to be reported. It does come in, and I know our FEs in the vital statistics group and injury and violence group work very carefully with our state toxicology lab and our state medical examiners and coroners to make sure the information can come in as quickly as possible. In fact, we're trying to look at whether or not we can provide even some preliminary results to give people an idea before the calendar year closes out on how things are looking. It's just, we have to be very cautious with that because it's preliminary. And so we're finding the best way to possibly ramp that up so we can be a little more strategic and have a little bit more current information. That is a challenge with this data source.
And do you have this geographically?
I believe the overdose deaths, some of them are available in other geographies currently online. Let me see if I can find one real quick and then we'll close out. But yes, some of these can't be displayed at other levels of geography because it'd be identifying potentially with small counts, but these ones, for example, are available at the county and the county little communities of health level, and you can actually map some of these. So here, for example, is all fatal drug overdoses combined. And sorry, the map isn't fully loading. I think we've got a lag on here, but these counties would color in once you get it to load properly. So yeah, some of these we are able to make available at a county or college, but I'm not sure why it isn't loading in colors. Yes, you can certainly come back and select a region of geography with some of these in the map. See it spinning right there and trying to load. There it goes. So that's what it would look like when you actually can map several of these. With that, I do apologize, but I probably better run. Sorry, absolutely. And again, some of these where you see the cross hatches is not because there aren't a lot of deaths there, it's because some of the data points are kind of challenging, or there might be unstable rates with low numbers they're trying to work with. Some of the challenge too, as you can imagine, especially when we get the PMP data, is they don't trust the click-a-tat data, for example, because almost all their patients get their prescriptions filled in Oregon at Good River. So, all right, for that I'm going to run.
Okay, thank you, Chris. And before we have the group split, we were joined by a couple of members of the task force, and I'd like to ask you to introduce yourself briefly. So that would be Roger and Randy and Don.
Hello, I'm Roger Ludwig. I apologize for being late. I was actually chairing a family medicine section meeting at my hospital this morning at 7, so the drive was rough, but I got here. I am a board-certified family medicine physician practicing urgent care in Silverdale. I'm an osteopathic physician, so I'm on the osteopathic medical board. I'm a flight surgeon with the Air National Guard, and that's me. Sorry I'm late.
Thank you. Let's come around here.
My name's Frank. My name's Randy Anderson. I'm the chair.
Hold it up close, please.
Chair of the podiatry board, president-elect medical staff at Peace Health United General Hospital. Again, traffic, trying to find this room. My apologies.
Good
morning, I'm Donna Poole, I'm the vice chair of the Nursing Commission. I'm a psychiatric nurse practitioner, and I have no good excuses for being late other than general disorganization.
All right, thank you. All right, now we're going to invite those of you who would like to adjourn to go to the prescription monitoring project in the other room. And if the rest of you would like to stay here, we are going to shift gears and begin reviewing draft rules. If there's a handout at the back table on your way in. If you didn't pick that up, there is a copy of draft rules. What I'm handing out to the task force here is an annotated version, which you will see on the screen here. And the annotated version describes focus areas we'd like this group to particularly pay attention to, and also those sections that we will not be talking about today, but we'll be talking about in future days. We're trying to actually maximize the use of our time and focus the group's energy on areas that we expect there may be some interest in discussing in more detail. Do you want to say anything more than that?
Yeah, thank you, Debbie. I would like to just add a little bit of context and explain where this annotated version has come from. As you all know, the underlying requirement in House Bill 1427 is for 5 boards and commissions to promulgate rules. And you all do that as part of your regular work on your constituent boards and commissions, so I don't want to belabor that, but I do want to kind of re-ground us a little bit in what that assignment is, because I think it's important to remember that our responsibility in making rules generally, and specifically here, is, again, it's ensuring that a minimum threshold or a minimum standard is set for practice to ensure safe and competent care of patients. And I think one of the challenges that we're facing in the project, and it's good that there is a wealth of data out there and a wealth of guidelines and other tools that we have at our disposal. But I think one of the challenges we face is that we've got a lot of information that falls into the realm of best practices. And I think that one of the things that we tried to do early on with our first conceptual drafts was provide a lot of information. We started with the chronic non-cancer pain rules that you all promulgated in 2010 and 11, and added a lot of material in. And I will say it was kind of the kitchen sink approach. What we need to do now, however, is I think we need to look much more critically at what content is here that, again, meets that criterion of minimum standards for practice that ensure safe and competent care of patients. And so that's one of the lenses that I want you to look at this material with today as we go through this. And I've tried to go through imperfectly and highlight that as a thing to be aware of as we go through section by section. And what I've done is before each section, listed whether or not that's a section we're going to deal with today, what I think the overwhelming or overarching issue is, or issues are with that section. I've also highlighted text in that section that I'd like us to focus on as a way to get really detail-oriented with it. And then there may also be some marginal comments as well. But the goal is to really make sure that we're focusing on minimum standards. The other thing I want to have us focus on is, as you know, there are some sections in here that are written kind of as universal requirements. I also want you to have a very critical eye to, are these requirements truly universal as they're stated? So, do the requirements in that section apply equally to the person who comes into the ER for a sprained ankle when they get a single, initial and only prescription for a couple of weeks of opioids, as opposed to someone who has been in chronic opioid therapy for a number of years? And if you can't really answer yes, that they apply the same way and equally to both, then we need to talk about, does that need to be restructured? So those are my two, I think, primary asks. I think that is probably also a theme that you have seen and heard in feedback to these early drafts. So I think that's where we need to channel our energies today, is to get more detailed. So I'm kind of being heavy here and giving the being hard nosed and saying this is what we need to do today. So good job, bad job. But yes, sorry, you will get a electronic copy of this. I finished this up yesterday about 4 o'clock, which is why you can get a copy of it before this. But what I can do, I don't know if we have the ability to send to the task force now. Okay, so hang on, it will be arriving shortly. But what I would ask is that you look at this today with those two criteria in mind. And we're going to be very task-oriented here. Debbie and I are going to beat the drum, and if you get into side conversations, we're going to say, thank you for that. That's what that flip chart is for. We'll write it down, and then we're going to keep moving along. So, because I think we really do need today to get through the draft sections, many of the draft sections that we've been working on. We still have a number of topics left to go, and so we need to make progress on it. My goal is that the next draft that we look at will look, I think, substantially different from this one.
Okay, so you might remember that we have talked about 4 general topic areas and had guest experts in discussion. And those areas are acute pain, perioperative, chronic pain, and special populations. And this morning we're looking particularly at acute pain and perioperative. And so if you follow along with me, it's tiny little print on that, and if you're old like me, it's hard to look at, but it's also up on the screen here, and Sue's going to do her best to try to take comments along as we go. You will note in the first section, the little blue thing right there, little blue box, this is a category that we're not going to talk about today, but we'd like to ask you to read and send in your comments by December 22nd, okay? Because it's kind of general enough. Same thing with the second section. The second section on applicability. Again, we're not talking about that today. We're going to ask you to review that and send in your comments. Same thing with the third section. Review that and send in your comments. And now we're going to go to section 4, where you might remember this. What is it? He has a note here about this. Oh, I just wanted to point out in section 5, you want them to talk about that today?
I believe PMP is section 5, correct?
Yes.
Yes. We're going to wait Okay, I'm going to talk loud.
So we had a discussion at the Yakima meeting about PMP, and I think that we need to come back and talk more about, there is certainly more content that we need to talk about with respect to PMP. And that includes some of the work that Chris is doing with his group. That includes some of the work around provider feedback reports. So my recommendation is that we have PMP as one of our discussion topics in January. I believe Chris feels that his work in breakout rooms should be pretty close to done by then. And I think it makes sense to have him in the room, not only to talk about his historical knowledge of PMP, but also talk about the work he's been doing and how it bears on our work. So my recommendation would be to save that for January.
Okay, so then let's move on to section 6. And this is what Blake was just kind of talking about, where the provisions of this section apply universally across all phases of opioid prescribing, from any old person that walks in the door or not? Your comments or thoughts about that?
And I should say too that the absence of comment here, at some point we will need to make changes, and so staff can either make changes and draw assumptions about what you all wanted to say, or you can give us direction. So that's the I'm holding to your head. So
I think this whole section belongs in chronic. I don't think it says any place in acute carry out.
It looks a lot pretty verbose for a chronic emergency episode. It involves a lot that isn't involved in
And so you recall, this informed consent section was pulled from the chronic pain rules. So that's the origin of it. And I think that, yeah, what we're getting to is, are there informed consent requirements that are substantially different for that acute patient who may only be getting a few days? Okay, you think that they are the same requirements for acute patients and for chronic patients?
No, I'm saying I don't.
You don't think that they are?
I don't think it applies. Once again, we're trying to provide safety and not make it onerous for that ankle sprain.
Comment?
Totally agree with that.
Sorry, we can't take public comment. Barry, you guest expert? We'll take public comment. You can sign up for the public comment period at 11 o'clock. Thank you. What did you say, Roger?
I was just saying, I agree with Randy on that. I think it's not appropriate in the acute case setting. And of course, it came out of the chronic rules, so it makes sense to us.
Yeah.
Focus that way.
Yeah.
Okay, so what are we? Yep. Expert comment here?
I understand it was taken from the chronic, but for unused medications and those unused medications, that should be something that should be considered more universal, even for acute use, to give information to the patient about that. And that's where a lot of the issues are. So
Yeah, I'm just saying.
what's important to say, maybe skip this whole part and say, what are the 2 or 3 things that we should include if we're in a hospital given a prescription?
Okay, just, I'm going to take
No, that's good.
So I thought that we had added this section for units of acute for the educational part to stop them from becoming chronic. But I agree that acute pain is your ankle sprain, this might be a bit much, so it should include, if anything, that's subacute and chronic.
So I wanted to kind of jump in off of Dennis's comment. I think that that's one of the things that I want to get feedback from you on is if they are not universal requirements, then and we can certainly take a stab at drafting this and bringing something back. But I mean, I think that there probably are informed consent requirements that you would want for acute patients, but they're probably a whole lot less exhaustive than you would want for chronic patients. Is that a fair statement? Okay. So then I guess we're happy to take a stab at drafting something for you in that regard. But when you give your feedback back to us on this section, it would be extremely helpful for you to say, you know, these are really the 2 or 3 or 4 things that you think are most important for acute. These are the things that I think are probably more acute or more important if somebody's moving in the subacute phase. And then what do we need at chronic? Or do you need an additional informed consent section at subacute?
What do we mean by informed consent? Is this an actual document to have to sign? Well, we're trying to.
Right, and that's one of the things that I highlighted in my margin comments here, as we talk about putting, you know, documentation in the patient record, but we haven't specified when. Are we going to do this at every prescription? Are we doing this at the beginning of treatment? So feedback also about what you think is reasonable. I mean, if we're talking about an acute phase from 0 to 6 weeks, is 1 informed consent sufficient? And then at subacute, do we need another informed
Wait,
consent?
are we at the
No.
doorstep to work this now? Rather than pushing it off? You want this now?
Well, I guess what I would say is, I want to be mindful of time, so we have a lot to move through, but if there are distinct or explicit suggestions you can offer now, I think that would be great. If it turns into a long conversation, what we will probably do is ask for feedback, but I am all for people putting ideas out on the table now, so please.
So number one, I would say not a good.
Yes.
Number two, I think we're treating the use of the medication for a specific issue differently from how we're treating other medications for specific issues, and I'm not sure that's reasonable. If I'm going to prescribe an antibiotic, I'm going to prescribe for this complication. This, for an acute issue, I think is not totally appropriate. I think there are areas where it is appropriate. We do need to talk to the doctor. And I think there are things that come from this that we ought to accept. But I think we should be cautious about treating this differently from how we treat other medications that have potential risks on them.
Yes, comment?
So one comment I have. So the one comment that I think about this is, from a pharmacist perspective, if we're saying that if there's no informed consent and not a documented diagnosis, that it may not be a valid prescription. So for the pharmacist to verify that the informed consent has been obtained, as well as the corresponding diagnosis for chronic or the varying kind of subsets.
No way.
That's
It's
not
untenable in practice to inform consent, something like this on every prescription you write.
And that's my question.
Yeah.
How do we ensure that that communication is there?
But how would you do this for any other medication? Right.
Claire, do you have a comment?
I don't think we should have informed consent. I think we have like best practices in a sentence. It's minimum number of medications and some advice about the dangers and addiction of before it can be done using small amounts. So just a best practice sentence about it versus informed consent. Because I think there's going to be some departments in large organizations that see the words informed consent and it gets way long out of
This is verbal caution.
Well, and like Dept just said, how is that enforced? And again, this kind of brings me back to my earlier comment. I think one of the things we have to be mindful of is, and you're going to hear more about this when Tammy Thompson, our regulatory affairs manager, presents later, and also we're going to hear from, I believe, both from Lily and...
Yeah, I think I ran right over them and let them speak yet, so we'll hear them later.
But they're going to be here to talk a little bit about the enforceability aspects of this rule and these rules.
This particular one, I think, doesn't need enforcement.
Yeah.
Because if it's education of best practice, we don't enforce education of best practice.
And that's exactly the distinction I need you all to make is if it's going to be in the rule, we need to focus on those things that are enforceable and things that, you know, again, provide that minimum standard. So that's not to say that we don't have a role in our 5 boards and commissions, our 6 boards and commissions in educating our populations. And there, you know, like I said, there's a wealth of guidelines out there. There are educational materials we can put together that enforce education and outreach methods that we can use to educate our providers. But I think we have to be, you know, we've been kind of a little lax about using the terms and the ideas of rules versus guidelines, and we need to get a little tighter about that from now
So
on.
is there any situation where you want to have informed consent be a rule?
I think when every year set of cues is not features, it needs a statement of best practice would be to have a discussion like you do with any other medication.
Dr. Santos, could you say what you said again?
We'll dispose.
I just made a comment about, information about safe disposal.
Oh,
what to
yeah.
do with unused medicine.
That I think is universal.
Probably, I think we go under best practices, with risks, benefits, and appropriate disposal of these medicines. That's it. Now we talked about subject.
Blake, did we not talk about early on in this that it doesn't have to be, what we bring to our board doesn't have to be just an enforceable rules, but at the same time, in the same document, we were going to be able to put in exactly that, a best practice, recommended guideline in the same set of rules that aren't enforceable but are there to go to the board?
So here's the caution I would offer you about it. And I think would I say that there is never room in a rule to create a statement of best practice. No, I wouldn't say that. I think that as you look at the chronic non-cancer pain rules, you see a lot of shoulds. And shoulds are things, and again, I don't want to steal Kristen and Lori's thunder, but shoulds are not shalls. And so I think that we need to be, again, very mindful of when you put something in a rule, two things. One, is it enforceable? And it doesn't necessarily have to be. But the other thing is, are you creating an implicit standard?
So in this case, I think we're all clearly saying that we want verbiage in this rule about shoulds, which gives us best practices for acute prescribing informed consent, right? So shoulds, but not shalls in this piece.
So, but I'm going to push back a little bit because I think we have to be cautious about coming up with a document that is not useful. And what our constituents need is what are the rules, and they need to learn what best practices are, the way they're looking at the disease process. And I'm a little uncomfortable about putting very many shoulds in anything that we do here. Is this something where we ought to include that? I'm not so sure it is. I think that ought to be part of any educational program that we do. I'm not sure it belongs in the rules though.
I apologize. I need to break this conversation because I inadvertently left out a context-setting piece of this discussion, and that person is the two people that are going to speak to that are just here for a short period of time. So I apologize. I need to interrupt this discussion. Keep your thought, and we're going to hear from Lola Lopez and Kristen. I can't remember Kristen's last name.
And hopefully this will help, actually having them speak now.
Help shape your thinking.
In terms of how we go forward with further conversations on rules.
If you guys want to sit or stand, whatever works for you. And danger.
So thank you. I'm actually going to be here for the whole day. I sit back at that table, so if you guys have legal questions, I am back there, although I do see the back of a lot of your heads. Kristen's going to talk about how it works in litigation with respect to rules and guidelines. And I just wanted to kind of go back to the basics, and I know you all do rulemaking on your individual boards and commissions, and you are familiar with this, so I don't mean to tell you what you already know, but now that we've come to the place where you're really going to dig into the rules and start deciding how they should look, it just seemed like a good time to really focus in on this. So as you guys know, you all have your individual AAG advisors, and Heather and Gail are here today as well, so if you have questions of them, they're here too. And so the process, at the end of the process, they will be reviewing the rules for your individual boards and commissions, and I'll be looking at them for you guys and for the department. So this is just kind of a way to let you know what we'll be looking for. But, and again, I know that you know all this, but I just wanted to go back very quickly and then hand the microphone to Kristen, just to make sure that you guys are remembering the underlying statutory authority. And I know we all know that it's out of 1427, and it's very broad rulemaking authority to adopt rules for establishing requirements for opioid prescribing. But we also need to keep in mind and remember that the existing pain management rules are there, and I know those are acknowledged in the current draft. But the underlying statute to those rules, the so-called 2876 statute, which was the name of that bill, is still there. It's still within your board and commission statutes, and it coexists with this new rulemaking authority. So those authorities need to be harmonized, and you need to keep in mind that 2876 mandate with respect to the chronic non-cancer pain management. And then also consider how the new rules will look in relation to the current rules, and by that I mean, are these current rules so comprehensive? Is that the intent, that they will be the only thing that will be in your rules chapter, and the existing rules will be repealed? Or will these rules be interspersed? Or,
how is that being thought of? And that just might help you to sort of have the framework as you're working through this. So in terms of the current statutory mandate, I know you guys are considering rules versus guidelines, so I was looking at that, at the law with that thought in mind. And the current law, the 1427 law, does say shall adopt rules. Whereas the 2876 law said shall adopt rules, and then it actually in the statute called for some guidance within the rules. This law doesn't do that, it just talks about adopting rules. So that's also something to keep in mind when you're going through and trying to decide, what's rules and what's guidance. And as Blake mentioned, in terms of what's the difference between the two, well, guidelines just simply aren't enforceable. So that's also something important to keep in mind. There are other ways to develop, an agency position. Rulemaking occurs under the APA, and the APA provides for other ways to develop an agency position, and that's policy statements, interpretive statements, which you guys may be familiar with. Those aren't really relevant as I read them. I mean, those are about a position or interpretation of a statute, but here you don't really have a statute that you're interpreting, you're just exercising some rulemaking authority. So those processes aren't necessarily relevant to this. And there are a lot of existing guidelines already, which you guys are also using to help you develop these rules. And the other thing I wanted to mention about the existing rulemaking authority is it does allow for exemptions. So when you're thinking about, should versus shall, you can have a shall, you can have a mandatory rule, but you can have exemptions if it's consistent with the bases that are allowed within the statute. And you might also just want to consider there are other folks also interested in this right now. Our office, the AG's office, is also working on some possible legislation. The governor's office is doing the same. So this is really your opportunity to get out in front and apply your expertise and come up with something comprehensive. In conclusion, with respect to what we'll be looking for in reviewing the rules, we'll be looking for consistency with the underlying statutory authority, both of them, and then just also enforceability with respect to the way the language is written.
Hey, is this one working? Like that? Okay. I'm Kristen Brewer. I work in the Attorney General's office, and my role is prosecuting cases on behalf of boards and commissions. So just to remind you, once you authorize a statement of charges and that case does not resolve short of a hearing, I'm the one that puts on that case at hearing, and you make that decision. So when we talk about statutes and rules, we're really talking about that segment of people that we're binding, because your best practitioners follow best practices. They're familiar with your guidelines and your policies. When it comes to a hearing, and we're talking about holding somebody accountable for prescribing that you thought was not okay, what are you going to be able to hold them to? Not a best practice, not a guideline, not something that's aspirational, only a statute or a WAC. When we do a hearing, when we issue a statement of charges, remember, we are limited to the conduct outlined in RCW set forth by the legislature, 18, 130, 180, and there are 25 subparts which you're all too familiar with. A sub 4 being a standard of care violation, and I'll come back to that. A sub 7, 18, 130, 180, sub 7, a violation of any state or federal rule or law regulating the